In systemic therapy, we came from the period where there was chemotherapy alone. Then we added targeted therapy with some clear benefits, and we now add immunotherapy with some clear benefits. And so this inevitably means we will have to make choices for patients, perhaps not choices between A and B, but often choices in sequence as well. What do we use first? Do we use first A and then do we use first B? So for targeted agents, it's not so difficult, because for targeted agents, we have quite sound biomarkers, and EGFR mutation for EGFR TKIs is the most known one, and there are many others to follow. For immunotherapy, we don't have a solid predictive biomarker like EGFR mutation for TKIs, but we do have a certain biomarker, PD-L1 expression in the tumor measured by immunohistochemistry, and we realize it's not a perfect biomarker, but it's certainly linked somehow to activity of these agents in different data sets, even in the patients with squamous cell non-small cell lung cancer. Although less clear and perhaps not statistically significant, there is clear a relationship between PD-L1 status of the tumor and activity of immunotherapy. So we do have a certain biomarker. It's not perfect yet, and there's room for improvement. The data are mature to report 2-year overall survival, and actually it's 22%. This is quite remarkable in relapsed non-small cell lung cancer, and I think it's very meaningful. It is a phase 2 study, so in that perspective it's perhaps a bit less relevant, but what we have seen from the 1-year overall survival data and from the 1.5, the 18-month survival data, is that the phase 2 data and the phase 3 randomized data, they really mirror each other. So what has been seen in the phase 2 is very representative for what has been seen in the phase 3 randomized trial. Meaning, if they report now in the CheckMate 063 a 2-year overall survival rates, it's probably quite reliable, it's significant in terms of clinical benefit, and it will probably be in place in the phase 3 as well, but there the data are not mature yet, but that is what we expect. The CYTOSCORE is looking for cytokines involved in the immune response, so close to the mode of action of these agents, of course. And what they did, they looked at relationships between overall survival and a whole group of cytokines involved in the immune response. And they filtered out 14 cytokines that had some relationship with overall survival. Then they assigned a certain value to each of these cytokines by a point system. What they reported here is in the phase 3 randomized data, where you have a comparison, they saw that the patients with a good CYTOSCORE clearly had a better overall survival outcome than the patients with a bad CYTOSCORE. This biomarker predominantly acted as a prognostic factor, meaning patients did better. Patients with a good CYTOSCORE did better with nivolumab, but they did better with docetaxel as well. So it has a relationship with overall survival, but it's predominantly prognostic. Maybe there's some predictive in it as well, and that would be great, because PD-L1 immunohistochemistry is a biomarker but far from perfect. So if we can have new elements for this to predict who are the people that really benefit from immunotherapy, that would be a big step forward.